end this session. Thanks a lot, Dr. Sarita. For the next session, I would like to invite Dr. Nitin Pant. He's an additional professor of pediatric surgery at King George Medical University, Lucknow. Dr. Nitin.
Thank you, ma'am. Good evening, everyone. For the next presentation, which is titled Simulations in Pediatric Surgery, I invite and introduce the chairperson, Dr. Ram Samuj, who is the professor and head, Department of Pediatric Surgery, PGI MER, Chandigarh, and also Dr. Arvind C.S., who is a consultant pediatric surgeon in the Government Medical College, Thiruvananthapuram. I request them to introduce the speaker. Dr. Ram Samuj.
Good evening, everyone.
Good evening.
Good evening, sir.
Good evening, Professor Mahajan and Professor Shilpa. Where is my friend, Dr. Khaizer Mansoor? He is there?
He's there, sir.
Good evening, Dr. Khaizer.
Good evening.
Salam alaikum.
Salam alaikum, sir.
It gives me great pleasure to introduce Dr. Khaizer Mansoor. I have known Dr. Khaizer since 2004, when we worked together in Riyadh, Saudi Arabia for almost 2 years. Then he moved to UK for better opportunities and settled there. I have had fond memories of the time we spent together in Saudi Arabia with our families. Most of you may not be aware that he is a wonderful cook, and I was fortunate to have his guest on many occasions. Dr. Khaizer is a keen researcher on top of being a clinician and surgeon par excellence. Now I request my co-chairperson, Dr. Arvind, to introduce Dr. Khaizer Mansoor. Dr. Arvind, please.
Thank you, sir. Dr. Khaizer Mansoor, MBBS, FCPS in pediatric surgery and MRCS in Glasgow. He has also obtained pediatric MIS from Leeds, UK, and fellowship in European Board of Pediatric Surgery and FRCS in pediatric surgery. He's a consultant pediatric and neonatal surgeon and urologist in Jenny Lind Children's Hospital, Norfolk and Norwich University Hospital, Norwich, United Kingdom. And his areas of special interest are neonatal surgery, minimally invasive surgery, urology, vascular access, and upper GI endoscopy and internutritional devices. He has a keen interest in teaching both undergraduates and postgraduates and nursing students. He has also interest in clinical governance, risk management, and communication skills and guideline development. He is a surgical tutor in pediatric surgery for pediatric surgical trainees and surgical trainees. He is a faculty at Sprint and FRCS in pediatric surgery in international preparatory schools. Sir, you can you please start your talk, sir? Dr.
Thank you very much. Thank you. Thank you very much for the to the Indian Association of Pediatric Surgery for inviting me for this talk. The previous talks have been obviously very, very high tech. I'm not going to be that high tech. One thing which I would add on the previous talks is that artificial intelligence worries me, because I'm a believer in the fact that someday it will take us over and wipe us as a race. Although many people believe that won't happen, but the way artificial intelligence is progressing, that may well become a reality. So I'm, to be honest, really worried about it. So I'll start sharing my, I'll try to share my screen. Just give me a second. It's not giving me the share option. I think you take a break because I'm really embarrassed because why
No
this is
problem.
happening. This is
No
because
problem.
this
We
shouldn't
have
be
announced a
happening.
5 minutes break. Anybody wants to?
So, Dr. Shilpa,
Okay.
we
Yes,
start with next session.
Are the chairpersons here for the next session? Virender is
Mani
here.
Gupta was there. Coordinators are there. I can see Dr. Nitin James Peters and Dr. Virender is also here.
So Dr. Mani is there and Dr. Professor Muthurangam is also there.
Okay. Dr. Krishna Kumar. Dr. Manjusha will not be joining.
Yes. I'll call Dr. Krishna Kumar if he can join now.
Yeah, if he joins-
I'm online. I'm online.
Okay, sir. Okay, you're from the JIPMER side. Hello, sir.
Divya, are you there? Yeah, she's there.
Divya is there, ma'am.
So
So we
we,
can play the first. Yeah.
so first let them start. Dr. Nitin, you can call for chairpersons and we can start.
Right, sir. So, good evening, everybody. And this is one of the most exciting, parts of any conference, and for the research conference this year, we have a good 8 free papers from centers from Delhi, Chandigarh, and mostly from Delhi and Chandigarh, and a lot of surgical trainees and residents are presenting their work which they have done. So I'll request my co-coordinator, Dr. Virender Sekho, to introduce the first chairperson. Dr. Virender, please.
Hi, good evening, everyone, and welcome to this session. Thank you, Nitin. Nitin, you can go ahead with the chairperson introduction.
Right. Okay.
It's running a little late, so I'm still on the road. Sorry.
Sure. So the first chairperson for today's session is Professor Ramanujan from Malaysia, former professor and head from Malaysia, a very active member, and sir was there for the recent SPU Con also. Welcome, sir. And the second chairperson is Professor Krishna Kumar from JIPMER, Puducherry. Good evening and welcome, sir. And
Thank you, Dr. Nitin.
Welcome, sir. And Professor Mani Gupta from the Mohali Medical College, professor and head at that center. Dr. Mani, ma'am, good afternoon and good evening and welcome to this session.
Thank you so much, Nitin.
I'll request the chairpersons to, mark the presenters in real time so that we can compile the marking and give the results to Dr. Shilpa and Professor Mahajan. So the first presenter is Dr. Divya, and Dr. Divya has actually given 3 papers in this session. Dr. Divya, please, can you share your screen and present your first paper on complications with delay in removal of DJ stents during the pandemic?
Nitin, that they have recorded videos. So the first one will be
right, ma'am.
shared from Chandigarh. The second and third will be sharing.
This is first video.
Right. Thank you, sir.
Good evening, respected chairpersons and all the delegates. I'm Dr. Divya and presenting on complications with delay in removal of digestants during the pandemic and their management. Double-J urethral stents are used for internal drainage and they are mainly inserted after urological procedures like pyeloplasty, pyelolithotomy, ureteric reimplantation, and iatrogenic urethral injuries are traumatic partial urethral injuries. And if the digestants are in situ for prolonged duration, they can lead to complications like migration, breakage, encrustation, stone formation, and occlusion. And rate of encrustation increases if indwelling duration is prolonged. During the pandemic, elective surgeries were postponed for more than 6 months, and on the other side, patients were not able to report to the hospital because of the pandemic. It's a prospective observational study over a period of 18 months. Patient demographic data, primary surgery after which degestenting was done. Time gap between the degestenting and removal were noted, and complications with the delay in DG removal and the management options were studied. In the first case is a 7-year-old female child with a single left kidney with PUJO. The child was having a renal failure and had 2 episodes of dialysis, and PCN was inserted in a private hospital, and then child was referred to us. DJ stenting was done after pyeloplasty. This patient has crossed ectopia. DJ stent removal was planned after 3 months because the patient reported late. Intraoperatively, the lower end of the DJ was not visualized in the bladder, suggesting the proximal migration. And this is the picture in that single kidney with crossed ectopia. In this case, ureteroscopic removal of the stent was done. The second case is a 7-year-old female child with right-sided renal calculus. This patient was also referred from another private hospital after DJ stenting. DJ stent was in situ for 15 months, and on cystoscopy there is encrustation of the DJ. Open cystotomy and removal of the DJ was done, and this is the encrustation of the DJ at the lower end. And the case 3 was a 6-month-old female child. DJ stenting was done after pyeloplasty in left PUJO, and the patient came for DJ stent removal after 9 months. And on X-ray, there is proximal migration of the DJ stent. It was removed by nephroscopy. We have inserted guide wire into the renal pelvis as in PCNL. After that, the tract was dilated. Then nephroscope was passed, and the stent was removed with the forceps. And the fourth case was a 10-year-old male child. DJ stenting was done after right pyelolithotomy. Patient came for DJ removal after 11 months, and there is stone formation at the upper end of the DJ, and removal of the DJ was done after PCNL. And fifth case was a 12-year-old male child. In this patient, redo pyeloplasty and DJ stenting was done. Patient came for removal of the DJ after 2 months, and there is distal migration of the DJ stent, which was removed by cystoscopy. This is the distal migration of the DJ stent. The conclusion is complications like stent migration, encrustation, stone formation, and fragmentation do occur in children if the DJ stent removal is delayed. And even complication like knotting of the 2 DJ stents if bilateral stenting was done can also occur. And management include multimodal endourological approach, and endourological techniques such as cystoscopy, ureteroscopy, PCNL, and percutaneous cystolithotomy are essential armamentarium for pediatric surgeon to manage these complications.
Thank you, Dr. Divya. And interesting set of cases with all the delays we've had with the COVID pandemic. So I'll request the judges, Professor Ramanujan, sir, your comments and questions and insights on this paper.
Yeah, because of COVID, there are a lot of problems like this that are happening, and without also, there were cases reported because of delay in reviewing the patients. And these are known complications with the DJ stents. And since these, I just like to ask why if the patients with DJ stent, they are considered as semi-urgent even during a pandemic. Was there any provision to call them back and get it done earlier?
Sir, actually, after elective surgeries are started, we call all of them. But even by the time they were posted for removal of the DJ, we have all these complications.
Okay. The others can ask.
Yeah, Dr. Mani and Dr. Krishna Kumar, sir, any questions from your end? Or Dr. Divya?
Yeah. Dr. Divya, can you tell me what all the precautions we can take so that it doesn't happen in the future?
First thing, we have to counsel the parents for properly report, timely reporting to the hospital for DJ removal. And the second one is we have to make sure that the soft coil at the upper end and lower end, soft coil at the upper end should be in the pelvis completely, and at the lower end it should be completely in the bladder. And adequate length DJ should be taken so that there won't be any migration. And even in cases of renal calculi, complete stone clearance may help, because if there are any residual stones, they may adherent to the DJ and they can act as an idol, so that it will lead to more calculus damage.
Okay, thank you, Divya. So, Dr. Krishna Kumar, sir, any questions from your end?
Yeah, just a couple of questions. Dr. Divya, you said delay in removal. So what period do you consider as delay?
Sir, in our institute, we usually remove the degestions after 4 to 6 weeks. Sir. If after 3 months, if they came after 3 months, if they reported to the hospital, we will consider it as delay in removal.
Okay. The other question is regarding the size of the stent. How do you determine the size of the stent?
Sir, we usually take age plus 10 as the size length of the device.
For example, if the TPD was a little larger, very redundant pelvis, does that change your DJ stent length?
Sir, if the pelvis was redundant, we'll take a larger stent than the recommended.
Okay. And the last question is, the ultrasound or X-ray, do you use that as a routine means to evaluate the lower end of the stent or upper end of the stent? Do you look at it, or is that your protocol?
Yes, sir. Intraoperatively, we have CM also. We will confirm that with under CM. And even on the post-op day also, we will confirm the DJ stent position by X-ray.
Thank you, Dr. Divya.
Thank you, sir.
Okay, there is one suggestion or a comment from the audience. Dr. Mahajan has said that, he maintains a separate register first called the stent register in his OR, so that may help in calling these patients back. So that's something to, think about. So thank you, Divya. We'll go on to the next presenter, Dr. Nitish Kumar. And this is also a pre-recorded presentation, and I request Dr. Shilpa to please play Nitish's presentation. It's about early predictors of stromal complications for temporary diversions.
Introduction. The creation of temporary intestinal stoma remains one of the most commonly performed surgical procedures, both in adults and children, and is done for a variety of clinical conditions. Unfortunately, this seemingly simple procedure is associated with multiple complications, the incidence of which varies from 6% to 96% in different series. The knowledge of factors which are associated with higher morbidity in patients with intestinal stoma is of great importance to the operating surgeon, as not only one can prognosticate the patient's recovery, but can also avoid or correct the factors which lead to poor outcome. Aims and objectives of this study were to find out the predictors of early stomal complications in children below 12 years of age with temporary abdominal intestinal stoma, to find out the incidence of various complications in children undergoing temporary intestinal stoma, and to evaluate the statistical significance of each predictor in causing a particular stomal complication. Method. The study outline was a prospective study conducted in the Department of Pediatric Surgery, Lok Nayak Hospital, over a period of 2 years, starting from December 2015 to November 2017. Children below 12 years of age requiring temporary intestinal stoma were included in this study, whereas children with intestinal stoma having no complication till 30 days post-operatively, children with collagen disorder or immunodeficiency, children requiring early stomal closure or getting lost to follow were excluded from this study. Variables included were age, hemoglobin, perioperative serum albumin, underlying pathology, presence or absence of abdominal sepsis, presence or absence of generalized sepsis, routine or emergency surgery, type of trauma, experience of surgeons, ASA score. The outcome or complications occurring within 30 days of surgery were defined as early complications and were broadly classified as minor and major complications. The minor complications included were peristomal skin excoriations, superficial sloughing of stoma, and edema. Wound infection, wound dehiscence, bowel evisceration, stomal bleeding, stomal retraction, stomal stenosis, prolapse, and parastomal hernia were included in the major complications. Statistical method. The data was entered into the MS Excel sheet and analyzed using the SPSS version 17. The descriptive statistics in the form of mean and standard deviation or proportions were used to characterize the study sample, which were divided into two groups of major minor complications. For quantitative data, the difference between the means of two groups were compared by t-test or Mann-Whitney's test. For qualitative data, chi-square test or Fisher's exact test were used to observe the difference between proportions for independent groups. Further analysis was carried out to find out the most important predictor for any complication and for specifically major and minor complications. Observations. Out of 40 subjects enrolled in the studies, half of them were neonates. 2% of subjects had congenital problems, whereas 38% of the subjects had acquired problems. Of all causes leading to ileostomies and colostomies, the maximum number of subjects presented with Hirschsprung disease. This was followed by anorectal malformation, which was followed by tuberculosis. Low hemoglobin with respect to age by its normal value was seen in 21 cases, that is 52% of the subjects. Very low serum albumin below 2.5 mg per deciliter was found in 11 cases, that is 27% of subjects. More serious complications were associated with ileostomies in both neonates and older children. The incidence of minor complications was 62%, exceeding that of major complications at 38%. The maximum number of complications occurred in the age group below 1 year, with neonates forming half of the study population. Majority of the stomas made for congenital causes had minor complications, that is 80%, while the ones made for acquired causes landed up with major complications, that is 66%. Of 15 patients with intra-abdominal sepsis, a large proportion developed major complications and only 20% had minor complications. 11 cases with hypoproteinemia, a larger proportion developed major complications and only 12% had minor complications. Similar findings were seen in previous studies also. 93% of the subjects operated in emergency developed major complications as compared to 48% of the subjects who developed only minor complications. The chances of major complications for emergency surgery were 9.5 times higher as compared to the routine surgery. Proactive measures should be taken during the perioperative period to avoid the stoma-related complications in order to improve the quality of life of the patient and to avoid any major complications requiring redo surgery.
Okay, thank you, Nitish. You can switch on your video. I can't see you. Yeah, so that you can interact with, yeah, hello, you're there. So thank you for that paper. It is a dreaded complication and a lot of morbidity and sometimes even mortality and a lot of financial implications to stomas which are there. So I'll request the Honorable Chairpersons, Professor Ramanujan sir, your comments and questions on Dr. Nitish's paper.
Well, this paper analyzes the complications mainly due to the nutritional problems which is happening in these children. And I think the preoperative nutritional support and correction of albumin levels and continued postoperatively will probably bring down the complications.
Right. Thank you, sir, for that comment. So, Nitish, before I go on to ask Professor Krishna Kumar about his comments. Did you do any multivariate analysis in your data? I know it's not a very large number of data, but did you manage to do something to kind of pinpoint what was the main factor for your problems?
Yes, sir. We did a multivariate analysis on this sample size, but after that we got only 3 major significant factors for the children undergoing early complications. One of them were low serum albumin. Another was this ASS score. Children having high ASS score were also having major complications, and another was this children having emergency surgeries. These 3 factors were came out to be as emerging as significant factors for early stomal complications on multivariate analysis.
So, okay, so taking that forward, Dr. Shilpa has asked how do we explain the difference between the emergency and the routine operations? Is it the same theater? Is your infection rates in the theater different, or other environmental factors are different in both situations? Obviously, they are different, but what are the exact factors? Because your paper says that you want to predict the early complications.
Yes, sir. Regarding emergency and the difference between the emergency surgery and the routine surgeries, the children who were having anorectal malformation, for whom we can't wait for posting up to the next routine OT, those were taken in the emergency surgeries, and surgeries were performed there only. For other children, such as high-sprung disease, for patients who were requiring pre-operative workup, those patients were taken in routine OT, and we had compared about the outcome in both the cases.
Okay. Dr. Virendra?
Yes, Dr. Nitin. Before we move on to the next one, I believe Dr. Dhruv had a question to ask. Dr. Dhruv, can you please unmute? Yes.
I'm just going on to what, going beyond what Dr. Shilpa had asked. It goes along with what the world sees, that the chances of a complication are much higher in emergency, in an emergency surgery and in an emergency setting, which is fair enough. My question is, were you able to identify, or did you find any physician or surgeon related factors to increasing the number of complications that happened in your emergency setting? Because 9.5 times is a very interesting number. It's fairly high and probably on the higher side of the spectrum. Did you find that there was some lacunae or some deficiencies in post-operative care that led to complications, other than the fact that they might not have good albumin, etc., etc.?
Emergency surgeries were mainly performed by the residents in our department, and but regarding the difference between surgeries performed by the consultants or residents, there was no significant change in the data. Regarding the experience of the surgeon, more than 2 years or less than 2 years, there were higher complications with the surgeon who had experience of less than 2 years. But on performing the test over that, we didn't find any significant change between regarding the experience of the surgeons performing the surgery.
Right. Dr. Krishna Kumar, do you have any comments?
Just one question. Thank you. Dr. Nitish, what corrective measures do you propose to take up? Because you said corrective measures are the same. So what corrective measures do you intend to?
Sir, regarding corrective measures, if the patient is having low albumin, we can perioperatively give transfusion to the neonates or children having low albumin values or low hemoglobin values. As far as regarding surgeries to be performed, we can convert an emergency surgery into a routine surgery. For example, in high-sprung disease, if the patient can be managed with rectal washes, so we don't have to push the patient to emergency surgeries and perform a colostomy over there. We can wait and let the bowel decompress with washes and then place the patient in routine surgery, which has more chances of getting this less complications in the patient.
With regard to transfusion, you referring to albumin transfusion or blood products? What is the
albumin transfusion and transfusion of this PRBC.
Thank you, Dr.
Yes.
Will you call one of your senior persons to come and help you if you are a junior resident?
Yes, sir.
Will you call your senior resident to come and help you, or your on-call surgeon, an assistant surgeon or a consultant on call, if there is no assistant surgeon, to come and help you when you are
Yes,
doing?
sir. Yes, sir. We usually, if we get any complication on table with the neonate, we always call the senior person, that is our senior resident or the consultant on call for that matter.
Sure. Dr. Mani Gupta, your comments or questions, please. Dr. Mani, are you there?
Yeah, I'm there. No questions, please. I want to ask about the corrective measures, and Sir has already asked. Thank you.
All right, great. Thank you, Nitesh, for that great presentation. So we move on to the next presentation. That's by Dr. Mansa Reddy from PGI Chandigarh, and she'll be presenting on histopathological differences between high insertion versus normal insertion of ureter in cases of uretropelvic junction obstruction in children, a prospective study. Mansa, all yours.
I'm going to present our prospective study titled Histopathological Difference Between High Insertion of Ureter and Normal Insertion of Ureter in Cases of Uretropelvic Junction Obstruction in Children. Have no disclosures or conflicts of interest. Uretropelvic junction obstruction, as we all know, may have varied clinical presentation and may present at any age with symptoms of lump, pain abdomen, infection, or hematuria. Also, the intraoperative anatomy is not always the same, and the question remains unanswered whether the same process occurs across all ages and presentations. The aim of our study was to identify histopathological differences between the high insertion of ureter and normal insertion in patients presenting with uretropelvic junction obstruction. It was a prospective study conducted between 2017 to 2020 and included all the children less than 12 years of age who presented with uretropelvic junction obstruction and excluded those who underwent retropyloplasty or had associated vesico-ureteric reflux, vesico-ureteric junction obstruction, crossing vessel, or had prior history of pyonephrosis or pigtail drainage. All the patients underwent standard investigation protocol and operative procedure, and ultrasound, EC scan, and intravenous pyelography were done preoperatively, and further Anderson-Hines open pyeloplasty was performed. All the suture-oriented specimens as shown were crossed, and sections from representative areas, that is pelvis, UPJ, and ureter were taken and assessed by expert histopathologists blinded to the intraoperative details. All the representative sections were assessed for fibrosis, edema, acute and chronic inflammation, and smooth muscle hypertrophy and graded accordingly. Statistical analysis was performed using software RGUI version 3.6.1 and frequencies and means for all data were calculated. Chi-square test and Cochran-Manton-Heinzel chi-square test were used to assess statistically significant correlation, and all the tests were conducted at 5% level of significance. A total of 49 patients were enrolled and excluded 16 patients where 2 had retropyloplasty, 1 had associated VUR, 6 had associated crossing vessel, and 7 had prior history of pyonephrosis. And finally, included 33 patients for analysis. Coming to the results, male is to female ratio in our study cohort was 3.33:1, and mean age at presentation was 31 months and median age was 3 years. We did not note any statistically significant difference between the two groups. All the cases showed smooth muscle hypertrophy at the pelvis region, fibrosis, and smooth muscle hypertrophy at the UPJ region. At the pelvis, UPJ, and ureter, we noted positive correlation between high insertion of ureter with chronic inflammation. We also identified that high insertion of ureter with negotiable UPJ over 5 patients showed less fibrosis, whereas high insertion of ureter with non-negotiable UPJ showed 28 patients showed no difference in fibrosis compared to the normal insertion. First picture, arrow denotes the increased inflammation, and in the second picture, arrow denotes increased smooth muscle hypertrophy. Different theories have been proposed regarding the UPGO pathogenesis, and even high insertion of ureter may be because of intrinsic aperistaltic or stenotic segment, or because of extrinsic pathogenesis where external compression by the pelvis leads to urethral leaking. There is contradicting literature regarding the histopathology of UPGO, and confounding factors in the reported studies include that they are retrospective in nature, site of histology is not marked clearly, and intraoperative anatomical variation is not considered in most of the studies except for crossing vessel in one study. The strengths of our study include that it is unique, it is prospective in nature, and intraoperative details and site of sectioning are clearly defined. And the limitations include that there are small number of study subjects and there is no available literature to compare. To conclude, although UPGO cases have some common histopathological changes, high insertion of ureter showed more inflammation, and those with negotiable UPG segment showed less fibrosis compared to the normal insertion group. Thank you.
Thank you, Mansa. I believe that the audio was a little slow towards the second half. I hope it was clearer for the others, but I'm not sure. Anyways, Dr. Ramanujam, your questions, please.
The problem is, I couldn't hear the latter half of the presentation, but the initial presentation was clear, but I could see the slide. The question I would like to ask is, was there any evidence or any history of urinary tract infection? How long after the urinary tract infection history have they done the surgery? And secondly, the question of hypertrophy of the smooth muscle fibers at the level of the stenosis is a controversial issue, and when compared to the literature. These are the two things I would like her to just elaborate on.
Thank you, sir. Sir, in most of the patients in the study cohort did not have urinary tract infections in our cohort, so that we did not include. And coming to the other question of smooth muscle hypertrophy, we graded the smooth muscle hypertrophy in the histopathology according to the another paper which was published, which was validated in their study.
Or not from your study?
No. The grading which was used in the other study, we used the same one. That was the grading was validated in their study.
Okay.
All right. We have two questions in the chat box, Mansa. The standard ones, I believe, for all presentations that we have from PGI. Why IVP and why EC and not MAC3?
IVP we use in one of the unit, but not all the patients. And we have EC available in our nuclear medicine department, so we use that, not MAC3.
Sure. I guess MAC3 availability in India is also restricted to, very few places. So that's another reason. All right. Dr. Mani, do you have any questions, please?
Yeah, I just want to know, is there any difference in the size of pelvis between these two cases?
Between the high and the normal insertion of ureter, ma'am?
Yes, between the high and normal insertion of ureter. Is there any difference in the size of pelvis you have found?
We did not find any statistically significant difference, ma'am.
And is there any surgical difference in the treatment, or the surgery was same in both the cases?
Surgery was same. We performed in all the cases. We performed Anderson-Hans pyeloplasty.
Okay, thank you.
Mansa, is it Anderson-Hines or is it like a modified Anderson-Hines? What is it exactly that you do?
Modified Anderson-Hines.
You've been stating Anderson-Hines all along, right? Okay, anyways. Dr. Krishna Kumar, your question, please.
Yeah, Dr. Manasa, on what basis the high or low insertion was determined? Because you said on some cases IVP was done and you said it was not done for all cases. So can you please clarify?
No, so in in all the cases which were included in this study, we had done IVP.
Oh, so the whatever high or low was based only on the IVP images.
No. Also in the intraoperative, we saw the difference where the normal insertion was mainly in the dependent position, whereas the high was obviously higher than normal.
Okay, meaning the IVP picture correlated with your intraoperative finding?
Yes, sir. In most of the cases.
Okay, but there was a discrepancy between the IVP as well as intraoperative finding.
In few patients where we did not note the high insertion of ureter on IVP, but we did find it intraoperatively.
Because that was not highlighted in the paper that you presented. Anyway, one more suggestion is, did you look at the ICC? Was that your objective as well, in addition to the fibrosis interstitial cells of Cajal?
No, we did not look at that, sir.
Okay. Thank you, Dr. Mansa.
Thank you, sir.
Thank you, Mansa. Some food for thought for you, I guess, to ponder on later.
Yes.
Good presentation, nevertheless. Thank you. So we move on to our next presenter, who is Dr. Bharat from Jabalpur, and he'll be presenting on genetic polymorphism associated with hypospadias in Central India, a case-controlled study. I see a question in the chat box, sorry. Okay, I guess Dr. Farman is still stuck to MAC3, and he's posting that question to all panelists, that you request post-op MAC3. I'm not sure where he's from, but may I answer it on behalf of most of the panelists here?
Pakistan, presently working in Muscat.
Okay, fine. I mean, to my knowledge, MAC3 is available in a very few limited centers across India. We have one here in Gurgaon, but I'm not, and that is also a recent phenomena. Most of the times our access to MAC3 is not great across India, so that will be a restrictive factor. It's not that, yeah.
Okay, Virendra, can I add one more point?
Sure, sir.
The EC also has got a low background activity. In fact, that way EC is also quite good. Thank you.
Right. Thank you. Sorry for the interruption, Dr. Bharat. You may please start your presentation.
Mahajan, sir, it will be played from.
Yeah.
You'll have to unmute.
Very good evening to everyone present here. I am Dr. Bharat Shiva, President, Department of General Surgery, Netaji Subhash Chandra Bose Medical College, Jabalpur. Today, I am going to speak on my topic on genetic polymorphism associated with hypospadias in Central India. As we all know, that hypospadias is the most commonest congenital urogenital anomaly affecting the newborn child. Studies all over the globe has shown that there is an increasing incidence of hypospadias, which has ranged from 1 in 600 and it has increased to 1 in 250. Various studies which were screened from PubMed, Embase and Google, which were systematically screened for the data available since 1910. A total of around 90 billion births were screened, and their corresponding data indicating the incidence of hypospadias continent-wise was depicted as follows. Also, the EuroCat report from the 2011 showed an increasing prevalence of hypospadias. An Indian study conducted at the Premier Institute of AIIMS, New Delhi, depicted that there was an increasing trend of incidence of hypospadias, which ranged from 7.66 to 9.33 in a span of around 8 years. What was the reason for this increasing incidence? Some researchers all over the world have proposed a multifactorial etiology which might have caused the development of this disorder. They include maternal exposure to chemical pollutants or endocrinal disruptors, industrial or agricultural waste of pesticides in a genetically predisposing individual. However, genetic cause per se can't cause so much of hypospadias, but severe hypospadias cases are associated with familial or hereditary origin. In India, genetic association remains largely unexplored. There is only one study from AIIMS which was conducted in 2011, which showed that SRD5A2 and CYP17 polymorphism were associated with hypospadias. We also conducted a case control study on the similar line to identify whether this genetic polymorphism existed in our population. So we conducted a case control study in our Department of Pediatric Surgery for a span of around 20 months. As it was a non-funded and it was a pilot study, we included only 20 cases which were matched with 20 control group of healthy children with a similar demographic profile. And we excluded children who had syndromic hypospadias, familial hypospadias, and hypospadias associated with disorders of sexual differentiation. Consent and ethical clearance was obtained. All cases were subjected to PCR for amplification of two predominant genes. The genomic DNA was extracted from the leukocyte by the standard salting out method. The PCR reactions were conducted following the protocol, and these PCR reactions were electrophoresed on 1% agarose gel, and the following results were obtained. This chart shows among the 20 samples subjected for RT-PCR, 4 samples showed amplification for both CYP and SRD5A2 genes, among which 2 samples showed amplification for both of the genes. However, none of the patients in the control group showed amplification for any of the gene. This chart schematically illustrates the interaction between the genotype and the environment concerning with the urogenital development. Also, there is a depiction of the main embryological events and the genes responsible. However, the last row shows the various environmental disruptors responsible for the causation of hypospadia. Thereby, I conclude my study stating that there is a potential association of polymorphism for CYP17 and SRD5A2 genes in hypospadias, which is as high as 20%. This study for the first time adds the information on this subject from Central India, and it's only the second study after the study conducted by Samtani in the year 2011. Limitations of our study were our smaller sample size and failure to subject the sequencing for restriction fragment length polymorphism, which was as a result of COVID pandemic, and ICMR took its lead role in this heat. A more elaborate sampling and sequencing can throw a light on the role of genetic polymorphism in the etiology of hypospadias. Thank you.
Thank you, Bharat. Right. May we start the questions with Dr. Krishna Kumar, please?
Yeah, Dr. Bharat, you talked about disruptors. Did you get a chance to look at them in the parents, please?
Good evening, sir. Sir, actually, this was a part of our a bigger study, sir, in which we had included all the cases of hypospadias. In parents also, we had rolled out familial and hereditary history, sir.
Okay, meaning, for example, the occupation of the parents, things like
yes,
that.
Sir.
Did you look at? Yeah.
Yes, sir. Majority of the patients who were from agricultural background, no, sir. The children of them, they had more incidence of hypospadias.
Okay, and then the type of hypospadias with the genetic polymorphism.
Yes, sir.
Now, what was the association, Bharat? Did you find an association? That is what Dr. Krishna Kumar is asking.
Usually, ma'am, what we chose was mid-panel hypospadias patients, ma'am. So as they were more exposed due to proximal hypospadias patient, they would have some or other genetic association. So we chose only mid-panel hypospadias case for this control project. So there were association, and there was an association.
Okay, which means you had restricted your study to only mid-penile cases.
Only for genetic analysis, sir.
Okay, that's what. You didn't have a choice of, for example, proximal or distal, yes. Or yeah. Okay.
Yes.
Okay. Thank you, Dr. Bharat.
Thanks.
Dr. Mani?
I just want to ask him that initially he was saying there is no genetic association of increase in cases. So what he thinks that is the reason for these genes?
Per se, genetic disorders alone cannot cause so much of hypospadias, ma'am. In a previously genetically susceptible individual who might have silent mutation, these environmental disruptors may cause that second hit, which might lead to hypospadias, ma'am.
So that means, do you think these are mutations in the genes which we are seeing?
Yes, ma'am. Yes, ma'am.
And is there any family history in these cases?
No, ma'am. We have excluded those patients with familial hypospadias.
Okay.
Yes.
Right. I think on similar lines, Dr. Simi has also posted in the chat box that including DSD will interfere with results for isolated hypospadias, but I believe you already mentioned that those with ambiguous genitalia were excluded from your study. So that's taken care of. Dr. Ramanujam, your comments or questions, please. Dr. Ramanujam? You're muted, sir, if you are there. I can see him online, but I believe he's muted. Fine, so thank you, Bharat. Good presentation. You already have a comment. Yeah, so since you are from general surgery, it was a very good presentation from your side. Congratulations on that.
Thank you, ma'am.
Next video.
Yeah, Nitin, can you please take over?
Yeah, thank you, Vinder. The next speaker is, the next presenter is again Dr. Divya, and she's talking about the experience with the association of grade of injury with outcome in pediatric blunt abdominal trauma. So, Dr. Divya, Mahajan sir, the video needs to be played from your side.
Good evening, respected chairpersons and all the delegates. And I'm presenting on association of grade of injury with the outcome in pediatric blunt abdominal trauma. Trauma is an emerging epidemic and is the leading cause of mortality and disability worldwide, accounting to 60% of the childhood deaths. And abdominal trauma accounts to 10% of all trauma and is the third leading cause of death after head and thoracic injuries. It's a prospective observational study over a period of 5 years. All cases of blunt abdominal trauma below 12 years were included in the study. Penetrating injuries, thermal injuries, and sexual assaults were excluded from the study. Patient demographic data, organ injured and its grade according to CT and intraoperative findings and treatment given and the final outcome were recorded. And follow-up period was minimum of 6 months to 5 years. And EpiInfo software was used for statistical analysis and p-value less than 0.05 was taken as statistically significant. Total 68 patients were included in the study with male to female ratio of 3:1 and most common mode of injury was fall from height. And grading was given according to the American Association of Surgery of Trauma. They have given injury scoring scale for both the solid and hollow visceral organs, and the grading was not only based on the imaging criteria, it was also based on the operative criteria and based on the histological criteria. And majority of them sustained grade 4 injury, which is seen in 47% of the patients. And Among the solid organs, liver is most commonly involved, and in 25% of the cases, grade 4 injury was observed. This is the CECT abdomen showing grade 4 liver injury, and this is the CECT abdomen showing grade 4 splenic injury, and this is grade 4 kidney injury. And this is complete pancreatic transection with the handlebar injury. And this is the CECT abdomen showing a right adrenal hematoma. And among the hollow visceral injuries, jejunal perforations were seen more commonly. And among all the patients, 84% of them were managed conservatively, and laparotomy was done in 11 cases. Among them, 8 were the bowel injuries, 1 case of grade 3 liver injury with active bleeding, and 1 case of CBD injury, and 1 case of intraperitoneal bladder rupture. And this is the picture showing jejunal perforation. This is the duodenal transection between D3, D4 junction, and this is hematoma at the root of the small bowel mesentery. And this is the intraoperative finding of bladder injury, which is laceration of more than 2 centimeters, which are again grade 4 injury. And this is the CBD injury. And this is abdominal vascular injury. This is the left iliac vein injury with a huge retroperitoneal hematoma. Becomes grade 3 injury. And majority of them had good outcome, that is 88%, and complications were seen in 12% of the patients. And this was this grade of injury, these complications were not statistically significant as the p-value was 0.79. The complications observed during the follow-up were pseudoaneurysm of hepatic artery, liver abscess, non-functioning kidney, pseudocyst of pancreas, subacute obstruction, biliary stricture, and urinary incontinence in patient with urinary bladder rupture. And these are the APSA guidelines for hospital stay in solid organ injuries, which is grade of injury plus 1 days, and activity restriction was grade of injury plus 2 weeks. And the take-home message was there is no direct correlation between the grade of injury and final outcome. In case of higher grade of injury, these patients had good outcome even in both lower grade of injury and higher grade of injury.
Right. Thank you, Dr. Divya. So we are running a little behind time, so we'll just take a question each from the judges. Professor Ramanujan, sir, any questions from your side? So we'll, I think sir is...
He was unmuted, but there's still some trouble with the audio.
Yeah, I'll go to Dr. Krishna Kumar, sir, your questions and comments on this paper.
Yeah. Dr. Divya, a few questions. Did you get a chance to analyze whether it was isolated versus multiple organ injuries, mode of, for example, high velocity?
No, sir. We have not taken the velocity of trauma into our study.
Okay. And again, with regard to the operative versus conservative management, did that have a bearing?
Sorry, sir?
Operative versus conservative management.
Yes, sir. In solid organ injuries, only 1 case was operated by us, that is grade 3 liver injury with active bleeding. And among the hollow visceral injuries, 8 cases were operated, and all the hollow visceral injuries were operated.
And did you do a DMSA and follow them up for hypertension and all that in
Yes,
renal injuries?
Yes, sir. In higher grade kidney injuries like above grade 3, 4, and 5, we follow them with DMSA standard, and during the follow-up, we'll report the BP also, sir, but none of the patients had hypertension during the follow-up. And 1 patient had non-functioning kidney, which I have already mentioned in the presentation.
Thank you, Dr. Dev.
Thank you.
Dr. Mani, any questions from your side?
Yeah, from her, it is clear that for solid organ injury, most of the time we are managing conservatively, and we are operating only on hollow viscous injury. Yeah. And any correlation with the age of the child and the injury?
No correlation, but in case of smaller children, polytrauma is more common. But for operative criteria, there is no correlation between the age and surgery.
Okay, thank you.
Thank you, ma'am. So, pediatric surgeons have led the way for non-operative trauma and in solid organ injuries by earlier studies and hallmark studies by Professor Upadhyay from All India Institute. So it's good to see this paper. Thank you, Divya. We'll move on to the next speaker, who is Dr. Charu Yadav, again from Delhi, and she's going to talk about the variations in levels of termination of TEF and characteristics of lower esophagus. Dr. Charu's presentation, please.
Yes, sir.
It will be played from Chandigarh.
Yes, ma'am.
I would like to present on variations in the level of termination and characteristics of tracheoesophageal fistula in the patients of type C esophageal atresia. As the morphological variation in the level of termination of TE fistula of patients of type C esophageal atresia are not well described in the literature, and there is no ways or methods to determine the level of termination of TE fistula. Hence, we took type C cases who underwent thoracotomy, and we did the accurate determination of the position of termination of TE fistula. The level of termination of TE fistula and the characteristics of lower esophagus near the fistula in the patients of type C esophageal atresia was. It was a prospective observational study and included all neonates who underwent thoracotomy over a period of 2 years for TEF. Intraoperatively, we identified azygous vein, upper esophageal end, and TE fistula, and we measured the distance between the azygous vein and the two esophageal ends with the help of 1A caliper, and we also measured the distance between the two esophageal ends, which contributes to the total gap. The patients were divided into 3 groups based on the total gap length. Shorter gap in group A, intermediate B, and longer gap in group C, and the characteristics of lower esophagus near the fistula, that is of wall thickness and the caliber, were also noted subjectively by the senior surgeon. The total number of cases in this study was 40, and the 2 types of surgical procedures performed, that is primary end-to-end anastomosis in 87.5% cases and primary diversion in 12.5% of the cases, and the incidence of post-operative anastomotic leak was 14.2%. When the patients were divided on the basis of the gap length, shorter gap length group A had maximum number of cases and group C had least number of cases. We assessed the distribution of tracheoesophageal fistula in the study group, and we found that the maximum number of cases had the fistula terminating below the level of azygous vein, and followed by fistula terminating above the level of azygous vein, and least number of cases terminating at the level of azygous vein. These are the intraoperative pictures showing the fistula terminating below the azygous vein, above the azygous vein, and at the level of azygous vein, respectively. We also encountered glue type 3B4 overlapping variety of TEF in 12.5% of the cases. We assessed the location of termination of distal TE fistula in the various gap length groups, and we found that the shorter gap length group has significant number of the cases with fistula terminating above and at the level of azygous vein, and least number of cases below the level of azygous vein, whereas longer gap length group had all the cases with fistula terminating below the level of azygous vein. The total variation in position of TE fistula was 15 mm above to 11 mm below the azygous vein, and the most common site of termination was 5 mm below the level of azygous. The mean value of the distance between the azygous vein and the TE fistula was also compared, and we found it to be significantly different among the 3 gap length groups, and hence it proves that the level of termination of the TE fistula also contributes to the variability in the total gap length, which remain elusive so far. The characteristics of lower esophagus were studied, and we found equal number of patients with narrow and wide lumen lower esophagus, whereas a maximum number of the patients had thick-walled lower esophagus, that is 75% of cases. The characteristics of the lower esophagus were also compared with the level of termination of the fistula, and we found that the patient at the level above the level of the azygous vein had more wide, significantly wide caliber esophagus, whereas they also had thick walled esophagus, but that finding was not found to be significant. We also assessed the characteristics of the lower esophagus with a total gap length, and we found that the group A, that is the shorter gap length group, has significant number of cases with wide caliber and thick-walled esophagus. The post-operative anastomotic leak was present in 14.2% of cases, and we also analyzed the cases with post-operative leak, and we studied the characteristics of fistula in these cases. Leak had significantly thin-walled lower esophagus. Vendasi et al. In 2008, before us, were the only one to analyze the level of fistula with the from the azygous vein. They did not report any case at the level of the azygous vein as we did. Koivusalo et al. In 2018 also retrospectively did bronchoscopy and considered TEF at the level of the carina, measurement of the distance of the TEF or the total gap length, as we did. Nagdev et al. In 2017 also analyzed the characteristics of lower esophagus, and they found more number of cases with wide and thin-walled esophagus, whereas in our study we found more number of the cases with thick-walled esophagus. The few drawbacks of our study was we had a smaller number of cases, and subjective assessment of characteristics of lower esophagus was done. I would like to conclude that the level of termination of the T fistula is inconsistent, and the commonmost site being 5 mm below the azygous vein, and it significantly contributes to the total gap length. Lower the opening of T fistula from the azygous vein, higher the total gap length. T fistula becomes thinner and narrower as it terminates lower down. Wall thickness of the lower esophagus plays a significant role in maintaining the integrity of anastomosis. Azygous vein may be preserved in cases with fistula opening below it. Thank you.
Thank you, Dr. Charu. Interesting paper. I'll take questions first from Dr. Mani Gupta.
Hello, Dr. Charu. Did you find any correlation between where the tracheoesophageal fistula is opening at the level of trachea, whether it is at the carina or higher it or lower it, with the level at the level of azygous vein?
No, ma'am. Actually, we did not do a preoperative bronchoscopy. As actually, if we would have done bronchoscopy, then we would have been able to compare these things. But because of our in-house problem, we were not able to do preoperative bronchoscopy. So we are not able to correlate between the carina and the opening of the TEF. We just did it with the azygous vein.
Okay.
Dr. Ramanujan, sir, your questions and comments on this paper?
Yeah, usually the fistula is open near the carina if you do the bronchoscopy. So we taking the azygous vein as the point, there will be variations in the level of opening of the azygous vein. So the better thing to confirm is by doing a bronchoscopy.
Yes, better would be to do it by bronchoscopy, but the characteristics by bronchoscopy we can just see the opening. We'll not be able to assess the total gap length during the bronchoscopy because the upper pouch is not visualized if there is no fistula, and this is the thing that we cannot measure the total gap length, and the characteristics also we cannot see through bronchoscopy of the fistula, mostly the wall and its contribution to the post-operative anastomotic leakage. And about the variability of the azygous vein, we did one study during this time also. We applied a clip on the level on the ligated azagus vein, and we did the post-operative X-rays, and we found it to be present at the level of T4 vertebra. And according to the literature also, the azagus vein is more variable in during its formation in the abdomen, but when it terminates, it is more or less constant. And we did this X-ray study also, and we found it to be constant. Then we went ahead with this study.
Okay, but anyway, you are going to assess the lengths on the table when you open. You are going to assess the gap by looking at with the measurement. You will know the measurement. So I was only suggesting it's because mostly the fistulas open at the carina. And was there any evidence of have you done any studies, further studies on these patients to look for gastroesophageal reflux, which was present in the thin or the thick ones?
No, sir, we did not assess the gastroesophageal reflux. We just the immediate post-operative complication we saw, that is leakage. उससे नहीं देखा सर, GER नहीं देखा.
Okay. Thank you.
Thank you, sir. Dr. Krishna Kumar, any comments and questions from your end?
Dr. Charu, any embryological basis or any basis on which you chose azygos and the level of fistula? I mean, is there any basis for that, or?
Sir, azygos is actually almost always present whenever we do the thoracotomy, and we used to ligate it to visualize the fistula. That is the general conception, that azygos is almost always there. And during our study also, we did not encounter any patient with azygos vein absent or even anomaly also. Those are very rare. So it was in our mind that we all the time we see azygos vein over there, and we have to ligate it to visualize the fistula. So it can be considered a landmark to actually assess its level of termination also.
Okay. Now, how did you control the surgeon suture technique between the patients?
Sir, the senior operating surgeon were two, and both one of them were always there during the surgery time. So the protocols were decided, and before only after ligating the azygos vein, before mobilization of the pouches, the fistula, when the fistula was divided, the distance between the azygos vein and fistula was taken, and before mobilization of the upper pouch, only stay sutures were taken and the distance between them were taken. Then this was the technique that was followed in every case, and the senior operating surgeon were same at that time.
The suture also was the same. Was there any change in suture material?
No change, sir. No change. We used to ligate the fistula with proline only, and the stay suture we used to take it with PDS. So they were same.
Anastomosis. For the anastomosis of the
For the anastomosis also we used to use PDS, sir.
Thank you, Dr. Charu.
Thank you, sir.
Thank you, sir. And thank you, Dr. Charu. We'll move on to the next paper, which is again by Dr. Divya from RML. And Divya is going to, discuss about awareness of research amongst residents in a super specialty hospital. So, Divya's video, please.
Good evening, respected chairpersons and all the delegates. I am presenting on awareness of medical research among the residents in a tertiary care hospital, a pilot study. India holds 12th rank among the productive countries in medical research with a global share of 1.59%, and medical research carried out by undergraduate and postgraduate students in India is not satisfactory. This is a prospective and descriptive type of study, and it's a cross-sectional study conducted over a period of 15 days based on a questionnaire, and convenient sampling was done. Residents from the paraclinical, surgical and non-surgical branches were included in the study, and undergraduates and faculty were excluded from the study. And this is the questionnaire. It includes 3 parts. Part A consists of the personal details like name, age, marital status, department and their designation, whether junior resident or senior resident. Part B consists of the knowledge-based questions like types of epidemiological studies, searching a database or literature review, and the knowledge regarding the confounding factors and types of errors, and the study variables like mean, median, mode, and standard deviation, and the ethical principles. And part C consists of practices on the research, like a number of articles they have published and whether they read the recently published journals or not. And lastly, it was included the obstacles in performing a research or conducting a research. And scoring was given from 1 to 10 based on their responses to the 10 knowledge-based questions, and descriptive analysis of the data was done. Based on the scoring, they were divided into 3 groups: below average if the score is less than 5, average if the score is 5 to 7, and average if the score is 8 to 10. Total 91 residents were included in the study. Among them, 15% were from the paramedical departments, and the non-surgical branches accounts to 48%, which includes both the specialty branches and super specialty branches. And the surgical branches accounts to 36%, which includes both the specialty and super specialty branches. And according to the scoring, there were none in the below average group, and 39% were in the average group, and 61% from the above average group. And among the study participants, 42% were the junior residents, which are in their MD/MS courses, and 58% were senior residents. And among them, only 48% had their publications. And among them, only 16% were the junior residents, and 84% of the articles were published by the senior residents. And only 54% of them read recently published articles. And among them, the participation in the institutional research workshops were seen in 42% of the junior residents and 47% of the senior residents. And reasons for not able to conduct or publish research work were lack of time and lack of teaching on this aspect, lack of interest, and lack of guidance. And suggestions from the study participants include to conduct more teaching programs or CMEs, and making them mandatory to attend those CMEs, because most of them are not able to attend because of their duties. And to conduct, they also suggested to have more interactive sessions and to allocate dedicated time and to provide guidance. And they also felt that genuine and standard articles should be freely available on the internet, and they should not be paid. And these study participants were interested in learning biostatistics, data management, and protocol writing. And the limitations of our study were short duration, convenient sampling was done, and single institutional study was done, which further limiting the generalization of the results. So the conclusion of our study is, even though most of the residents had fair knowledge of medical research, but its application into practice is limited, and conducting medical research is essential to improve the patient care. Including this as a part of medical curriculum, conducting educational programs or conferences oriented on research may improve the awareness about the research.
So thank you, Dr. Divya. Very thought-provoking, study which you have done over there. And I'll before I take questions from Dr. Ramanujan, I would like to welcome Professor Gangopadhyay, sir. Welcome, sir, and good evening. Sir is muted right now. I can't see him. So, Dr. Ramanujan, sir, your questions?
Well, the study is an interesting one, but as she already pointed out, that the research work that is done is usually, when you analyze, it's not usually a satisfactory research work. That's what she said. So one of the main problems which we face in the postgraduate education is when they are oriented with clinical work, especially surgeons, she should have studied the surgeons separately and find out, because they are on call, they are also doing the operative procedures, and they have to be, their time limitation is one of the factors which has to be considered. I am not sure whether you, the post-graduation for MCH is 4 years, 3 years or 4 years? 3 years. 3 years after your master's. So 3 years, they have to do a lot of clinical work. They have to obtain a lot of the newer technologies that they have to learn, the basic things. And that's why most of the overseas institutions, if you look at the FRCS or the FRACS, the UK and the training as well as the Australian training, their training duration is 6 years, but they call it as a surgeon scientist type of approach, and they do the qualification, or during the time period of the training, they take off for 2 years for an MD or 3 years for a PhD. So I feel we should ask our postgraduate trainees mainly to be on a case series or some retrospective studies and limit them, and probably do or interesting case report discussions in the thing rather than aiming for great thesis from them. One of the things, it stresses them too much along with a lot of clinical work and operative work.
Thank you, sir. Dr. Krishna Kumar, sir, your question or comment on this very interesting paper?
Yeah, a few comments and questions as well. Dr. Divya, how many, you gave the questionnaire to how many, and then how many responded actually?
But I have given personally to them, and I have given to 91 of them who are available. That's why I have mentioned that it was a convenience. Yes, sir.
Yeah.
91, I have given them personally the questionnaire, and I explained them if they have not able to attend some questions. After that, I have taken, it's like interview-based questionnaire.
And were there questions on grants and good clinical practice? I don't remember seeing them.
No, sir.
Okay. Okay. Thank you, Dr. Divya.
Thank
you. Dr. Manigupta, your question of...
Yeah, Dr. Divya, did you find any difference in scoring between paraclinical and clinical subjects? And between the clinical, any difference in scoring between surgical and non-surgical branches?
Ma'am, there is not that much difference in paraclinical, surgical or medical in my institute.
Because you have taken only 14 paraclinical and most of them were clinical. So in the clinical, any difference in scores between surgical and non-surgical branches?
Ma'am, there is not much difference, but I have not, because I have not grouped them only from the paraclinical this much sample, and from, I have not compared them in my study.
Okay.
You said 55% of them have said there is no time, not much of time to do the research.
Yes, sir.
55%.
Yes, sir. Lack of,
they didn't have much.
yes.
So I think very interesting facts which have come up with it, even though it's from a single institute, and it may, that the same thing may echo across institutes where surgical residents may be overwhelmed with clinical work and long duties. But I think there are a lot of senior teachers here, and efforts like this conference are efforts which kind of make most surgical residents aware of research, and it could be a very simple research question. So that's what it is all about. You don't have to go into very high-end research all the time. So a very interesting paper, Divya. And I'll request Virendra to go on to the next session. Next paper, sorry.
Well worded, Nitin. Thank you. The next and the last presentation in this session is by Dr. Meghna, again from New Delhi. Has it already started playing? Yes, please.
Sorry, it just started.
No worries, ma'am. We can play it.
Prevalence which ranges from 1 to 5% and 9 to 11% in full-term and premature neonates respectively. And it is also repaired by two common techniques, namely Gross and Ferguson and Mitchell-Bank repair techniques. Few retrospective studies have compared these techniques, but they were inconclusive about the preferred operative procedure. Hence, this study was planned to compare the incidence of early complications between two conventional methods of pediatric inguinal herniotomy. Material and methods. Prospective randomized study conducted at the Department of Pediatric Surgery of a tertiary care center in India. All males aged 1 to 12 years presenting to the OPD with uncomplicated unilateral inguinal hernia in 1 year were included, and children with any other medical or surgical conditions were excluded. Children were allocated in two interventional groups based on the two types of hernia repair techniques, with and without opening the external oblique muscle, by block randomization and matching with respect to age and site of hernia. Selection bias was avoided. In our study, blinding was not possible and IC approval was taken. All operations were performed by a single pediatric surgeon and a single preoperative surgical profile access was followed. Patients were discharged on POD 1 and followed up on POD 7. Short-term complications like fever, which was measured with thermometer on POD 1 and POD 7, with persistently increased temperature of 100 degree Fahrenheit, which was labeled as fever. Scrotal edema was assessed on clinical examination. USG was performed only in cases of scrotal swelling with pain, redness, and tenderness to document scrotal hematoma, and wound infections were perceived as superficial or deep. The data was entered into MS Excel, analyzed using SPSS version of 17. Descriptive statistics in the form of mean and standard deviations or proportions was used, and various tests for quantitative and qualitative data was used. Result: a total of 50 patients were enrolled and 25 each were allocated to the two interventional group. Mean age of boys who underwent surgery by GF technique was 6.5 years and by MB technique was 4.8 years. Although fever was present in 8 subjects, 2 out of 25 in GF technique and 6 out of 25 in MB technique on POD 1, while no subject had fever on POD 7. Duration of surgery as seen in the table was less than 30 minutes in 6 subjects with MB technique and 30 to 35 minutes in 14 subjects and more than 45 minutes in 5 subjects. Mean operating time when we compared, it was 26 minutes and 38 minutes in GF technique and MB technique respectively. So scrotal hematoma was not seen in any patient on POD 1 in either group, while one subject in MB group had scrotal hematoma on POD 7. The difference was not statistically significant. The discussion portrays the same. The duration of surgery was significantly shorter in inguinal hernia repair with GF technique than with the MB technique, although the incidence of fever in two groups was statistically similar. In a study by Nazem et al., the incidence of fever was 6.1% in MB technique and 9.1% in GF technique, which was statistically not significant. On the contrary, although statistically insignificant, but we observed higher incidence of fever in MB technique, and that could be explained on the basis of longer operating time and consequently higher surgical stress. Scrotal edema was significantly more in MB group as compared to GF group, and no patient had scrotal hematoma on POD 1 in our study, and there was no statistically significant difference with regard to the incidence of scrotal hematoma on day 7 between the two groups. Wound infection was not present in any subject on POD 1, and 12 subject has SSI on POD 7. And the statistically higher incidence of SSI on day 7 was found in GF group as compared to the MB group. But none of the patients had any deep surgical site infection. Limitation of our study include that it was a single center study and the sample size was also small. Conclusion: GF technique has less operating time, less incidence of scrotal edema and hematoma, but higher incidence of SSI, which suggests the need of more meticulous dissection. Thank you.
Virender, you are muted.
Thanks, Nathan. Right. May I request Dr. Ramanujam to start with his questions, please?
There are quite a few studies on this techniques, but I was just wondering why it was extended, and it was initially mentioned as a procedure of modern pediatric surgery, because it was as well as described much earlier in late 1800s. So the second one I was concerned is about the type of preoperative care they are taken to prevent the wound infection rate. The wound infection rate is high when compared to if it is properly prepared and patients have been advised. So I would like to know what type of preoperative advice they have given, and whether they advise to bathe them before the previous evening and the next day morning. And secondly, what type of antiseptics were used, and who are the surgeons who are performing that, because the incidence of scrotal edema seems to be quite high. So that's why I'd like to ask that.
Sir, for preoperative precautions, we usually go for a single dose of injection ceftriaxone or an antibiotic, and maximum we go for a second dose post-operatively on the POD1, and accordingly looking at the clinical aspect of the patient and whether the patient has passed urine or not, and then we decide for the discharge. This is what we take as a as far as the antibiotic protocol goes in our institution. Secondly, sir, the surgeon, the single operating surgeon was performing the same, all the 50 cases. And sir, for scrotal edema was only assessed on the basis of if there was a swelling or erythema. And scrotal edema was mainly it was seen on POD7 in 20% of the cases in Mitchell-Banks technique, and in 18% of the cases in it was seen on POD1. That is one of the patient had in Gross-Ferguson technique, and nine patients had in Mitchell-Banks technique. But scrotal hematoma, sir, the scrotal edema was only a clinical diagnosis, and for scrotal hematoma, we had prepared that we will only go for ultrasound or other evaluation if there are further clinical signs suggestive of it. But there was only one patient who developed scrotal hematoma, and subsequently it settled. And sir, for SSI in surgical site infection, there was more surgical site infection what we found in Gross-Ferguson technique than in the Mitchell-Banks technique.
So overall, the surgical site infection rate, I'm telling, is higher. So that's why I'm asking.
Sir, it was superficial only, sir. Looking at the one of the lacuna in our study can be that if we try to categorize the surgical site infection on the basis of the WHO standards, like they have those 3 or 4 criteria, but we only went for the, if there is erythema at the site of wound infection, then we label it as surgical site infection. We must have overrated this surgical site infection, because if there would have been a deep infection or a superficial surgical site infection, we usually open one of the sutures and we send the pus culture sensitivity, and then accordingly we modify the antibiotic looking at the clinical aspect of the patient as well. So in this study, in 50 patients, we only went for the local erythema, and we said that it was a surgical site infection. But definitely this can be included when we are planning to extend this study further.
Sure, Meghna. Nitin, you wish to make a comment?
Yeah, thanks. So I think I'll echo what Professor Ramanujan had said, that the SSI rate was high, whether it's Mitchell Banks or Ferguson's technique. So at our institute, we are usually, the first case is the clean case. We don't give any antibiotics, and the SSI rates are quite low. That is something probably which can be looked at, other environmental factors for that high rate. So that's
Sure. Dr. Krishna Kumar, your questions, please.
Just a comment as an aside to what Dr. Nitin had said. The role of antibiotics in a clean surgery, because hernia we generally classify it as a clean surgery. So, your comment, Dr. Meghna.
Sir, actually, this is an institutional protocol that we only go for a single shot of antibiotic before clean surgery. We usually don't go for a second shot or after post-operative. On post-POD 1, we don't go for any antibiotic, but so we go for a single dose of antibiotic pre-operatively.
Okay, and with regard to the grading post-operative complaint, was it the same person who did the surgery or it was a different person?
No, sir. He was the same surgeon who performed all the 50 surgeries. He graded it.
Oh, thank you, Dr. Meghna.
Thank you, sir.
Dr. Mani, your final questions or comments, please.
Yeah, I just want to ask her which type of sutures were used in both the cases, whether they were absorbable or non-absorbable on the skin.
Ma'am, I think we will, as we are planning to extend this study, we will include this criteria because we have not graded it as the suture which was being used. It would have been polygalactin or the nylon sutures. Good suggestion, ma'am. We'll include this in our study.
Okay. One more question: is there any difference in the social status between the subjects who are having surgical site infection and the patients who are not having?
Ma'am, mostly these patients were from the lower middle class strata, ma'am, whom we operated because we took these patients from our general ward. We did not include the patients who were operated in from the special ward or the different beds which we have in our ward or in the different building of the hospital.
Can I just one comment?
Yes, please.
One of the things which we did was we did a study in Chennai, and mostly they are coming from the lower middle class or even the lower class of the society. The one thing which we found was when we tried to clean these patients, we found there a lot of dirt. So we advised specifically that they have to give a bath with soap and water, well, the previous day in the evening, as well as the next day in the morning, and to bring the children so that there won't be any dirt or anything when we clean the things. So that one reduced the incidence of wound infection much considerably rather than giving antibiotics. So that will just one single dose of antibiotics and that should be enough.
Yes, sir, noted, sir.
Thank you, Meghna. I trust wonderful presentation. Before I close the session, may I request all the three judges to give their final comments on how our residents did in this session overall. Dr. Ramanujan, how did you like it? Yeah.
They have done it well, but they some of the things they could have been helped by other people so that they can come out with the research methodology and as well as the presentation. Particularly some of them, they could have been trained with the presentation slow, clear, rather than putting too much of material in one slide. So those types of things they can avoid. So that's the one.
Sure. I guess they are still learning and noting all that you are saying so that they make better presentations the next time. Thank you for your suggestion. Dr. Krishna Kumar, your final words, please.
I think they had a variety of topics which were quite interesting. Somebody who spoke on hypospadias for genetic polymorphisms, then azygos vein. I think quite interesting variety of topics. I think good presentations overall. Thank you.
Great. Dr. Mani?
Yeah, I agree. It was a variety of presentations. A lot of topics were covered, and which was actually interesting. Thank you. Thank you so much.
Thank you, and I'm sure that gives a lot of boost to our young colleagues who would develop more interest in research as they further in this specialty. So I thank all our chairpersons. I also thank Nitin, and would you like to make your final comments and close the session?
Thank you, Virender. I think kudos to the boy from Jabalpur. You know, it's good to see general surgery residents, presenting pediatric surgery topics, and that's always a way to catch them young. So that's all. And I think over to Professor Mahajan sir and Dr. Shilpa, and thank you on myself and Virender. Thank you.
Thank you, coordinators and chairpersons for session 6. You all have done a wonderful job. Organizers are grateful to you. And we will go to the last lecture of this previous session. We have been able to fix the presentation issues for Dr. Khizar. So Dr. Khizar, you can please start. Please share the slides for Dr. Khizar. Share. Dr. Khizar.
I think I'm able to share myself. Just give me a second. Let me see if you can. Okay. Okay, so I'll be sharing now. Let's see if it works.
Okay. Mouse. Apologies to the chairpersons for making you wait, but these are
no problem. We enjoyed the free papers.
Yeah, so if you can stop sharing not so much, then I can probably share my screen.
No, we have already stopped sharing.
Okay.
We have already stopped sharing.
So I think you can share. Probably it doesn't seem to be working from my end. So go ahead and share, and then I can talk.
Okay, share. Dr. Khizar.
Okay. Thank you very much, and sincere apologies for the technical glitch, because obviously this was not something which we were anticipating. But so as already told, I work at Norfolk and Norwich University Hospitals at the General and Children's Hospital, and I'll be doing a little talk on simulation in surgery. It's not very high tech, but I'm sure it will give you a bit of a flavor of what is happening on the front. Next, please. Next slide. Okay, a bit about the history of surgery. So there is obviously a lot of surgery which has been going on, but Ambrose Paré described surgeries to eliminate that which is superfluous, restore that which has been dislocated, separate which has been united, join which has been divided, and repair the defects of nature. So basically, we invented weapons first for hunting, and when we got sharp things at our hand, we thought, let's start doing some operations. I think the first operation which probably might have been done must have been an IND, and then excision of external tumors and dental extractions we know, and then obviously there have been attempts at internal operations. Next, please. Next, please. Yeah, so needles are also known from prehistoric times. Thorns were used as needles. No, go back, please. One slide. Yeah. So we know that ants were used for closure, which is the counterpart of modern staples. Trephination was known, fracture management and splints were known, and leeches were known for bloodletting. Next, please. Next, please. Next. Okay, so what are the steps of learning surgery? One is, no, that's going too far. Yeah, that's fine. So one is self-taught, including ideas. So all the great surgeons, which, can you go back to the previous slide? I think someone is moving them too fast. Previous slide, please. Yeah, thank you. So self-taught. So people thought of an idea and did the operation. Then people were self-taught, but they were text-based. So they read an operation has to be done, and then they tried to do the operation. Then people observed surgeons and then did the operations. Then there were apprenticeships where people would go and learn surgery, but not given a chance to operate. So they were non-hands-on. And then we have the surgical training we do now. So it is apprenticeship, which is hands-on. And last is simulation, which we are entering now, which is the new era. Next, please. So if you talk about development of surgical simulation, it's not something new. Actually, the first model has been about a nasal reconstruction, which is almost 600 BC. And then again, Ambrose Paré said that there has to be something done with cadavers. And then we got some great advancement, and then things improved in 1980 when we started developing mannequins. And then lab trainers came, which we are all familiar with. Now we have the ER, and the latest is obviously the robot simulations. Next, please. So simulation is not only done by surgeons. The industry which probably does the simulation most is the airline industry. And flying an aeroplane is only allowed once you have perfected the simulator. And it is hours and hours of simulation, and then you are able to fly a plane. Next, please. So just a few pictures about history. Obviously, if you look at these pictures, simulation was not possible because anesthesia was not developed in the first two pictures, and all the force and attention was trying to hold the patient while it was being operated upon. And then we came to the idea of operation theater, and it was actually a theater, as we can see in the last picture at the bottom, that people would operate. So I don't think you are seeing much. So it was more of just sitting there and just hoping that you see or catch a glimpse of the surgery. Next, please. So then we entered the modern era where we started teaching each other surgery, and we started developing course. So just to give an idea, so the Royal College runs the course, and this is just a picture of how to tie a reef knot. Next, please. We were doing open surgery for centuries, and then this happened. So we entered the era of minimal invasive surgery, initially with laparoscopic surgery and now with robotic surgery. So we had to somehow find a way to train ourselves to do these operations this way. Next, please. So what is the concept of simulation? As we said, it's nothing new. The idea is to practice and improve skills, not to risk the actual patient. Most important thing where simulation has come in is to transfer the skills which were used in open surgery to MIS, and then we developed the concept of dry versus a wet lab. Next, please. So what are the drawbacks of simulation? There is no stress because obviously a simulator won't bleed. There is no time pressure because there is no anesthetist saying that, oh, can you finish this sooner? There is obviously a difference in tactile sensation. There is a difference between perception, 2D versus 3D, although it is changing because now most of the simulators are going to be 3D. As pediatric surgeons, one thing which is very important is there is too much space available in all simulators, while as surgeons who operate on babies, we have very limited space. And then obviously if you make error, you can reverse it. So there is no risk. Next, please. So something about simulation is the Fitz-Posner and Kirkpatrick model. This was originally a model which was developed for motor skill development, but it can apply it in surgical simulation. It has three concepts. One is the cognition stage, which understands the task and perform in an erratic, distant steps. Next is the integration stage, where you improve, so your flow and smoothness comes with practice and feedback. And last is the automation stage, where you can perform with minimal cognitive input. Next, please. So the levels of the model tell that level 1 is assess the level to which the learner enjoyed the training. Level 2 is effectiveness to which learner was able to actually acquire the skill. In level 3, it's the ability to apply what has been learned. And level 4 is the extent to which the outcomes have changed depending on the modality applied. Next, please. So what is the attribute of an ideal model or an ideal simulator? It should be as close to life as possible. So we know that wet labs exist. Animals who are alive or anesthetized are usually not allowed in many parts of the world. It should offer a tactile feel. It should offer depth perception. It should be a small model for us. So it should limit space because that's important for us as pediatric surgeons. It should not compensate for tremors because all of us will have a degree of tremor, and it should give a feedback. So that would be an ideal simulation system. Next, please. So we have obviously open simulation from time immemorial. So we teach each other how to hold the instrument, how to tie knots. Then we have the dermal model. And then we have very advanced open models, like you're seeing one where a tracheostomy is being done at the bottom end. So there are very, very realistic models available, all for open surgery. Next, please. And then we move to the simulator. So this is the basic simulator. There is no screen. You're directly visualizing what you can do, and you can practice your simple tasks like picking colors or moving things around ropes and stuff. Next, please. Then you can have what we call as a box trainer, which you can usually, it is cheap. You can make it in the home in a shoe box or in any plastic box. You usually use your computer's web base. You can practice when you go home, and you can do multiple tasks as you can think, you can develop stuff. Next, please. And then you have cheap online options. So you can go and buy simulators online. They are quite cheap in price. They can work with your laptop. It's a personal investment, but for beginners, it may be worth it. Next, please. And then you have two types of institutional simulators. One is where you can see through from sides and top, where you can do a bit of cheating because you're not actually doing it the way it is done. The other ones are the closed boxes, which is what real life is. And there is no cheating possible, and you only have a screen version. Next, please. Most of us, I believe, practice endoscopy one way or the other, either at the top end, bottom end, or both. So we have simulators available which can be used for this, and they can teach you some basic skills. We do need it for upper GI as the minimum for pediatric surgeons. Next, please. And then you have urology simulators as well, where you can practice your cystoscopy and other stuff. Next, please.
Hello.
What are the issues? The issues are that with these simulators, they are based on fixed imaging. There's a lot of free space available, although they are cheaper, but they are less realistic. Next, please. So then you move to the next generation. So on the top, you can see that it is a simulator which is giving you a very reasonable anatomy, although it is all computer generated. But here it is very virtual, and it will bleed. It will tell you, the tissues will tear. So that will give you the real sense. And the next stage is obviously you're moving into virtual reality, which is the next phase of learning. So there are two types of VR, which we are talking about. And in one of the VR models on the bottom of the screen, you are actually seeing navigation through a MRI color-coded image. So that's a very high level of training. And interestingly, on the top right, you can see there are some video games available for surgeons to practice their simulation. Next, please. And last but not least, we talk about the robotic surgical simulator, which is a standalone. The cost is just of the simulator because you do not use any consumables or disposables. It does analyze your performance, which is extremely important. It can have add-ons for new surgical procedures. It doesn't need an operating room, so it can be placed anywhere. And then the monitor allows the procedure to be observed, and it gives you a comprehensive curriculum to train for motor and cognitive skills. And that's obviously the highest end of surgical simulation. Next, please. So in conclusion, more and more training will move towards simulation. Simulation will actually form few hours of certain curriculums in training, especially in England. There will be a section where you will have to do simulation and get it signed off. Simulation is going to form the basis of telesurgery, which is becoming a reality with the surgeon sitting in America and operating somewhere in Delhi or Pakistan, anywhere. But one very, very important lesson, which we should always remember, irrespective of any advances in simulation, the time spent with a master surgeon is completely irreplaceable. So at the end of the day, it is about working with a master and learning the craft of surgery from that person. Next, please. Thank you very much for your time. Any questions?
Thank you, Dr. Kaiser, for a wonderful talk on simulation in pediatric surgery. We enjoyed the talk, and now I request my co-chairs to see the questions in the chat box and get it to Dr. Kaiser for his valuable comments, if any. Anything is there? I don't think any question is there.
No questions are there. Sir.
No question? So, Mahajan, we can conclude the session.
I want to ask one question.
Yeah, please.
So it has been wonderful working with Khizar in Norwich in 2016. So we had a common mentor, Dr. Sang, who used to teach us on the simulator much before we go to the patient. So Khizar, can you highlight the importance of that simulator, the endoscopic one and the surgical ones?
So we are lucky in Norwich to have actually a full lab with us where we have multiple simulators. We have open simulation staff, we have laparoscopy, and we have endoscopies. So what I learned most of my laparoscopic skill, I must admit, from Mr. Sang and lots of other mentors. So Mr. Sang was a big believer of simulation, and he would say that once you perfect your simulation, you can transfer the skills to the patient. So I think he would always encourage us to work on a simulator, perfect our skills, and then gradually take us through the steps on a real patient. So I think that was what his ethos was, and that's what I strongly believe in as well. Especially for people, someone who have not been exposed to minimally invasive and have a lot of experience in open surgery. So it is actually quite a big transfer. So people who are learning or training, they will train in a very graduated and standard way. But people, especially who come from abroad, from India, Pakistan, other parts, to places where a lot of MIS is being done, they have done a huge amount of open surgery. They can do any operation in open surgery. But when it comes to MIS, they will have to transfer those skills. And I think the middle step would be simulation. I hope that answers your question, Shilpa.
Yeah. Do you have any idea about the cost of that endoscopic simulator for colonoscopy and gastroscopy?
I'm not sure about the cost.
Don't do that in India, but it was really useful.
I don't think so. I'm sure about the cost, because if you talk of the cost in England, everything is extremely expensive, as you know. But I'm sure if you look at it as you have done, it's not rocket science. It can be very easily manufactured in anywhere if a good doctor and a good engineer join hands. I think most of these simulators can be created at very low cost if we want to. So I don't think so we need to buy them. It's best to learn and see them and then build our own. And I think that manufacturing should be much, much cheaper rather than buying from sort of Western world.
We can request Dr. Sagar to look into that for pediatrics.
Yeah, I'm sure he's an expert on that.
Thank you so much.
Thank you.
Thank you. Thank you, Dr. Kaiser. Yes.
Yeah, continue, Mahajan.
Yeah, thank you, Dr. Kaiser. That was a very nice talk. We are sorry that there was a technical glitch, and
I feel very bad about it as well.
No, it's okay. It happens. So we are grateful to you and that you took time to talk to us. The organizing committee has made a small memento we would like to share with you, and it's a token of our appreciation for your time. Thank you very much.
It's an honor. It's an honor and a privilege. Thank you very much for the invitation. Thank you.
Thank you.
I want to thank Professor Mahajan for giving me this opportunity to chair a session which Dr. Kaiser Mansoor has talked on, because I thought this is a golden opportunity to meet Dr. Kaiser, because otherwise it's very difficult nowadays to meet Dr. Kaiser. Kaiser?
No, boss, you are welcome anytime, and we need to have a one-dish party very soon.
Yeah, still I remember the fire.
Chandigarh or in the
Yeah, no, you can come to Chandigarh. You wanted to take a taste of Patthar Kebab, no? You ask me one day.
Definitely. That's my next destination.
Yeah. Okay. Thank you. Thank you, Kajal. Please convey my regards to Sadia Mami.
Thank you very much. Thank you.
Okay.
Thank you so much. Thank you.
Thank you, Mahajan. Thank you.
Thank you. Thank you, Ram Samud sir. You have been here all the 2 days throughout. Thank you so much.
No. Thank you very much for inviting. No, we enjoyed because all the sessions were very good. Yesterday also, today also, all the topics were very nice, and even the free papers were very good.
Thank you, sir.
Thank you, sir. So we learned a lot because
session.
Yeah, you can close the session now.
Yeah, thank you,
Mahajan, sir. I thank all chairpersons, speakers, and all the paper presenters who participated today. And with this, we come to the end of the conference. And now we will start with the general body meeting.
Can we just have a short felicitation of thanking everybody, because some people may not be members of the GB.
Okay.
So Dr. Ramanujam, are you ready with the results? And Dr. Moni, have you compiled them or we need to check the scorecards?
I have already sent the results.
Okay. So we'll see from there.
We have sent the results, madam.
Okay.
Thank you so much.
Take some time to check our sheets.
So I will just put a note of thanks to all the organizing committee members, Dr. Simi, Dr. Jena, Dr. Kirti Rathore, Dr. Anand Pandey, Dr. Sagar Jai